Thank you so much for joining us today. Here within the Sanford Institute for Empathy and Compassion, we are very enthusiastic to be hosting this webinar on measuring empathy and compassion and to really kind of initiate a discussion with all of you about where the field currently stands, where the gaps are, and where we see opportunities for innovation going forward. Next slide, please. Today, we plan to focus on three main objectives as shown here. First, we will review key concepts related to empathy and compassion and endeavor to sort of summarize the current state of measurement in this space. Second, we'll identify critical gaps, areas where existing tools and approaches fall short. And then finally, we'll be sharing some of our early work at the Sanford Institute aimed at addressing these challenges and endeavoring to move the field forward. Next slide, please. Before we jump in, I would like to take a moment to introduce myself and my co-presenters today. I'm Cinnamon Bloss. I know I've met many of you, know many of you. I direct the Center for Empathy and Technology here at the Sanford Institute and the University of California, San Diego. I'm joined by Dr. Cassie Beaton, Director of the Center for Mindfulness, and Dr. Lisa Eiler, Director of the Center for Empathy and Compassion Training in Medical Education. And together we bring perspectives from research, clinical practice, and education, and hope to bring these perspectives forward as we kind of think about with all of you how to better measure the constructs of empathy and compassion. Next slide, please. All right, so I'd like to start by asking you to consider what brings you to this webinar today. You're free to share your thoughts in the chat. But kind of thinking about what situations, whether in your own work, your organization, or your personal experience, have made you interested in measuring empathy and compassion. Again, kind of feel free to share some of those reflections in the chat. Take a few seconds for that. Ideas about that? Okay, well, while you're thinking, we can go to the next slide. Oh, okay. I see Sarah's shared some thoughts, Mary, Christine, Greg, work around community engaged learning and seeking to use measures there. Federica, Becky, I'm considering a PhD in compassion and leadership in healthcare, a desire to hear updates on the work of the Institute. Well, thank you all for sharing these reflections. So I will just kind of add that we asked this question when you all registered for this webinar, and here is a sort of a visualization of what we heard from all of the registrants. And sort of breaking this down a bit more, some of the themes that you all noted, in addition to what we see here on the screen, in addition to what many of you are sharing in the chat, thank you for doing that. Some of the general themes were interest in professional development, measuring outcomes, applications in education and healthcare, and a desire for better tools and understanding. And if I've missed anything or there's anything missing on the screen, you can continue to feel free to add reflections in the chat. And I also invite you to think as well about kind of today's session and what you hope to walk away with.
I've seen a couple of people saying that you want to speak the language of people that need to hear the hard numbers. And I think that's a really important, useful tool that we can have for measuring things quantitatively, qualitatively, in a structured way. It can help for those people that say, show me the data.
Absolutely. Absolutely. Yeah, thank you. Okay, next slide, please. So I just want to start with some definitions. I think one of the biggest challenges in this field is that empathy and compassion are often inconsistently defined. I'm sure many of you here experience that, or they're used interchangeably, right? So empathy is best understood as feeling with someone. It's a multidimensional construct, and researchers typically distinguish between kind of two primary components. Cognitive empathy, which is perspective taking, the ability to understand a person's thoughts, feelings, or situations without necessarily sharing their emotional state. And then there's affective empathy, which is an emotional resonance or feeling what another person may be feeling and sharing in their emotional experience. And importantly, empathy can, of course, lead to different outcomes. In some cases, empathy leads to empathic concern centered around helping the person that you're feeling empathy towards. In other cases, empathy can lead to one's own personal distress, which can result in kind of avoidance or withdrawal. So empathy connects us to others, but doesn't necessarily kind of motivate us to act or move us to act. Next slide, please. And so, what is compassion? Compassion, in contrast, is specifically oriented towards suffering and is often described as the heartfelt wish or the motivation to reduce the suffering of others. And we think about compassion as having four components: cognitive, which is awareness or recognition of suffering; affective, feeling concern; intentional, wanting to help and relieve suffering; and then motivational, being ready to act to alleviate suffering. And similar to empathy, compassion has both cognitive and affective elements, but compassion incorporates intention and action. So while empathy kind of connects us to another person's experience, compassion kind of moves us to respond to it. Next slide, please. And these constructs, of course, matter because and I don't have to say that to all of you here on the webinar, of course, matter because they've been shown to have measurable impacts across multiple levels. And you can go through the animations here, Kim. Thank you so much. At the individual level, they've been associated with lower depression and anxiety, greater well-being and resilience. At the interpersonal level, research has indicated they're associated with improved communication, trust, relationship quality. And then at the organizational level, we've seen associations with better patient care, lower burnout, and higher engagement. And I just want to emphasize that what has made this research possible and what's really served as the foundation for beginning to understand these relationships is efforts to measure empathy and compassion. That's how we've been able to observe these relationships. So measurement is what allows us to demonstrate impact and ultimately to intervene and improve outcomes. And another critical point I'll underscore here is that is existing evidence that empathy and compassion can be taught, can be learned, which really again speaks to the importance of measurement in order to understand the effectiveness of these intervention efforts. Next slide, please. And you can go through the animations here as well. Thank you. So this slide highlights both the differences and the overlap between empathy and compassion. As I've mentioned here this morning, empathy involves understanding and emotional resonance, but isn't inherently action-oriented. Compassion builds on empathy, but is action-oriented. It involves recognizing suffering and wishing to take steps to alleviate it. And at the center, both constructs share key features. They're multidimensional, context-dependent, nonlinear, and again, can be cultivated over time. And these are kind of important, I think, commonalities and differences to kind of amplify as they become relevant when we think about measurement. Next slide, please. Okay. Before we go further, I'd like to put another question to all of you, another interactive component. I'd like to ask you all to think about, how do you actually know when someone is being empathic or compassionate? Or even not only how do you know when others are feeling or feeling in those ways or kind of behaving in those ways? How do you know when you are being empathic or compassionate? And so one way to sort of think through this is what's happening in your thoughts, what's happening in your emotions, or even your body. What are the bodily sensations? And also, what are you observing in others, their tone, their facial expressions, their behavior? So please do take a moment to reflect. And if you're willing, kind of share one insight about that process in the chat. And I see some things already coming in. Sarah says, because you can tell they're present and listening, they slow down and are focused on the other person. This is from Allie. When I'm being empathic, I'm being reflective. I'm slowing down the interaction. I'm trying to dig deeper. Anna says the other person's emotion is validated, not minimized. Cassie says truly curious, a sense of curiosity. Agree with that. Not trying to fix it, from Rachel. Not thinking of myself in those moments. My awareness is trained on the other person. Thanks, Lee. And Christine says the sense of emotional connection, capacity to notice what's going on with the other. Yeah, I think there's some kind of common themes and observations here. Thank you all for sharing. Alice says a stillness and not noticing much else than other than the connection. Thank you. All right. Let's go on to the next slide. So why measure empathy and compassion? I think as Lisa alluded to at the beginning, there's really growing interest in moving beyond kind of the intuition around empathy and compassion, beyond the kind of I know it when I see it sort of view, and really towards more systematic measurement. And so we measure empathy and compassion for several reasons: to understand current levels in individuals or organizations, to study underlying psychological and biological processes, to track change over time, particularly when we are seeking to understand the effects of an intervention. Also to provide feedback and support development, including professional development. Um, and so I think, we heard some of these themes kind of emerge in some of your comments as well. And I think these can help shape how we think about measurement strategies. Next slide, please. And you can move through the animation here too. Thank you so much, Kim. So when measuring empathy and compassion, there are several critical considerations. First, as we've discussed, these constructs are multidimensional, so we need to be quite clear about what we're actually measuring. Second, they're culturally dependent. What counts as compassion in one context may not in another. I think this is a very important area of measurement of these two constructs. Third, they're context dependent. Environmental constraints can shape whether empathy or compassion is expressed. And finally, they operate at multiple levels, as I've already mentioned here this morning. And they're time dependent. They can fluctuate. Most measures that are currently in use don't adequately capture that change. And we'll hear more about that a little bit later today. And so all of these factors and more can really make kind of measurement tools, measurement strategies complex and highlight why a number of our existing tools may fall short. Next slide, please. So just one more slide. I want to touch on the limitations of measurement, then I'm going to hand it off to Cassie. And it's just to say that despite the large number of existing measures, several limitations are present across the field. First, there's a heavy reliance on self-report, which is vulnerable. If any of you are psychologists or familiar with psychometrics, you know that this can be these sorts of measures can be vulnerable to social desirability bias. Second, there are relatively few behavioral measures, even though compassion is action oriented. Third, we rarely capture the recipient's perspective, sort of how compassion is experienced by others. And fourth, many tools lack cross-cultural validation, which I think is critical. And finally, most rely on single time point assessments, kind of missing the dynamic nature of these constructs. So when we sort of think about these limitations together, all of this points to a clear need for more robust, multidimensional, context-sensitive approaches to measurement, which is where we will go next. And so I'm going to go ahead and turn it over to Cassie.
All right, everyone see and hear? Okay, thank you, Cinnamon. I am also tracking the chat, and I'm really looking forward to hearing from some of you who are commenting and love to learn from you. So I want to share about some of the work that we've done. This was supported by the Sanford Institute for Empathy and Compassion, especially the technology division that Cinnamon heads up. And we conducted a scoping review of what measures are out there right now for empathy and compassion. And a scoping review is a little bit different than a systematic review in the sense that there isn't a quality assessment. In other words, we don't take all the measures that we find and say we're only going to include the ones that are high quality. Instead, we try to get our arms around the entire field of empathy and compassion measures, we did attempt to add a rough estimate of quality in the sense of looking at how often and how many types of validation had happened for each measure. But just know that this is telling you about the entire field of measures of empathy and compassion that are out there right now. And this does also exclude measures that are fMRI or biomarker measures. And so we have written a paper on this scoping review, and you can find it at the QR code in the upper left. You'll also receive these slides, I believe, after this webinar. And then we've created a compassion measures website and interactive data visualization, which is the QR code on the lower right, where you can actually go and put in the population that you want to measure, the construct, empathy, compassion, both, or other affiliated constructs like caring or compassionate communication. We'll get into that a little bit further. And then what type of measure. So even though in this scoping review we didn't include things like fMRI or EEG measures of compassion, we included self-report, behavioral observation, and patient report, things like that. So we asked ourselves what measures are available out there for assessing compassion and empathy in humans, it says, but it was also, we limited this to adults, and how have they been validated? We had quite a number of studies that we imported in for screening, 220,000, but we ended up including about 5,500 after we screened out studies that were actually relevant or that were duplicates, etc. And so what we learned is that there are over 250 unique measures of compassion, empathy, or related constructs out in the field right now. A small minority of these have multiple validations, multiple articles validating them, but a large proportion only have one article. And what that means to us is that somebody developed a measure of empathy and compassion, but they may be only used at once, or it just hasn't been tremendously validated. Kim, I do see there are several people in the waiting room. And so the vast majority of these measures are self-report questionnaires, and thus they are subject to some of the limitations that Cinnamon shared with you. And all of them, almost all of them, are completely face valid, and they're uncontrolled for correlation with social desirability. So what do we mean by that? When we say face valid, it simply means that they're just asking the person, do you feel compassionate toward your patients, or do you feel empathy? So the person actually has to have enough self-awareness that they can report that. And then when we talk about correlation with social desirability, obviously saying I care about my patients or I care about other people is highly socially desirable. And it takes a lot of self-awareness to say, I don't really have as much compassion as I wish I had for my patients, or I'm not kind to my coworkers. So it's a problematic to just ask people directly, how compassionate or empathic are you, because of these biases that can be associated with face validity or social desirability. This just gives you an image of the predominance of self-report measures as opposed to peer or corollary report. That just means asking their colleagues or asking a spouse or asking a patient, what compassionate did you feel this person was? Behavioral or expert coder has a little bit more objectivity. There's been somebody who's been trained in the signals and signs of compassion. So even if someone says, I'm really compassionate, an expert coder who's watching the interaction might say, yeah, but you didn't actually make eye contact. You didn't turn your body toward the person. When they got upset, you started to shrink back, things that you don't know that you're doing. And then physical instruments or objective reports that try to get at those things through a camera or through a wearable or something like that. Okay. So again, you can look at this article in PLOS One that we published on the study. There is a lot of interest. There's been about 14,000 views in the last 2 years. And you can go to our interactive data visualization. In the paper, what we really wanted to do was say, here are the measures of compassion and empathy you should use. That would have been ideal, right? If you're in this situation, use this measure. The problem is that every situation is so complex and so unique that what we ended up saying is actually you need to choose your own measure of empathy and compassion. But here is the process you can go through to choose which measure of empathy or compassion you want to use, or a related construct. And so sometimes we want to measure, is somebody experiencing compassion? Sometimes we want to measure, are they expressing it to their patient? Sometimes we want to know, is it impacting their health care? Are they able to stand in the patient's shoes? Are they able to elicit the patient's perspective? Do they have a a comforting way of being? And another important thing when you're measuring empathy and compassion in the workplace or in your particular setting is you might consider also measuring the opposite of compassion. Did the person express callousness? Did they express a lack of empathy? Was there an anti-empathetic attitude? Sometimes measures that are anti-compassion are even easier to make them reliable and valid than measures of compassion. So, kind of like I can tell when you're not doing it, it's a little bit hard for me to tell when you are doing it. So, the steps you might go through when you're selecting a measure for yourself is that you might first review the literature on the topic, and you might decide that compassion is the construct that you are wanting to measure. Let's say in this example that you're conducting a study of emergency room outcomes and you're looking at outcomes in relation to patient satisfaction, but also number of admissions, time from registration to discharge. And in this, you really want to include a compassion measure. So you review the literature on the topic, you decide compassion is the specific domain that you want to measure. And because you're aware of the limitations of self-report measures, you might decide not to use a self-report measure. You might decide that peer reports or behavioral tasks are not appropriate for the fast-paced environment, but maybe patient reports would be ideal. So then in step 3, you recognize that because of the fast-paced environment, the questionnaire must be quite brief, given the existing measurement burden and the limited time participants have. The population is emergency room clinicians and patients. And in this case, you really just want to get at compassion. You don't have to use multiple measures to see if it's distinguishing it from empathy or other relevant constructs. So in this case, when you use the online tool, you might select the population patients and the construct of compassion. That search would yield 8 potential measures. And upon reviewing each, you might find that the 5-item compassion scale has number 1, the sample items that reflect what you really want to measure. And it has been previously validated in emergency room patients and clinicians. And it has several tests of reliability and validity, ends up being the right choice for your project. So that is the kind of process you might go through when you're choosing a scale that you might want to use in your setting. So the opportunities that we have as we move into the future, we may want to work towards creating a brief mobile/desktop assessment of compassion and empathy that combines the strengths of self-report, also some task-based measurements that get at implicit biases, maybe using some face and voice analysis. We might use social and biomarkers in the lab. We really do want to ideally combine what does the person feel themselves, what does another person say they are acting like, and then find better ways to measure state and trait changes in compassion in response to intervention or developmentally over time as somebody's being trained or maybe gets their feet under them in your environment. So this is very important that we try to use as much as possible qualitative or mixed methods. So you can use that interview, focus group, subjective self-report, a written or voice diary. You might also, though, want to have the observer, the patient or peer report, and then you might want to have something objective, either video cameras or AI, machine learning, biomarkers. On that note, just like other fields of measurement, AI is beginning to have an impact on these kinds of measures of pro-social attitudes and behaviors. And so you can, whereas you might in the past have had to have a team of 15 coders bit by bit looking every second through videos, AI and machine learning can look through those videos and detect signals of compassion. We might use virtual reality both in our interventions and in our measurement for training purposes and for assessment purposes. I mentioned voice analysis. If you take recordings of people's voices, you can hear in them tension, distress versus comfort and flow. Embedded measurement means measuring people all throughout their experience of the intervention as opposed to just measuring them before and after. And that way, there can be a self-reflection or a formative kind of measurement where people are learning what gets in the way of their own compassion and empathy. And this is just an example of how we can use technology to measure empathy and compassion and to intervene. This is a virtual reality experiment that we also conducted with support from the Sanford Institute, where we took healthcare professionals into Compassion Island, which is a virtual reality environment where they can encounter various meditation trainings, mindfulness trainings, compassion trainings, self-compassion. This is an example of what the island looks like. And then after the healthcare professionals get training in these fully immersive environments that have compassion meditations and things like that, they are asked to go into a clinic and interact with a difficult patient. So this is kind of an example of what the clinic might look like. There they are entering the clinic after they've had all these compassion trainings. They're going in to meet with a very difficult patient named Ivan. This is his second time being arrested for a DUI. There was a passenger in the other car that had injuries. He's out on bail awaiting his court date. He's also very, very difficult and aggressive. And so, as somebody moves into that situation, while we all know that we would still have empathy for someone who is experiencing addiction, it can challenge empathy when somebody has both a difficult time, a difficult attitude in their let me try to get out of this video. Sorry about that. Um, I'll stop sharing for a second and rework this here. Okay, and so as people interact with Ivan, we're measuring them the whole time. And one of the interesting things we found, in addition to the tone that people used, or how patient they were with Ivan, or when they felt challenged, how did they self-regulate? But we also showed EEG suppression of a mu signal, which is related to responses on compassion and self-compassion scales. And so another group at UCSD, in addition, used Compassion Island to look at the effects of medical students' racial biases, potential racial biases. And so they were able to vary the skin color of the avatar in the clinic. One of them was white, Miss Elizabeth Brown. One of them was black, Miss Lakeisha Johnson. And so as somebody interacts with the patient, you can see how many words do they use? What kinds of diagnosis do they give? What kind of prognosis do they give? Do they give a worse rating to one color versus the other color? And so they're still analyzing those data, but some of the data indicate that the responses to the African American patient were a bit more negative than they were to the white patient. And so this isn't really a gotcha scenario. I wouldn't recommend that you use it for assessing whether somebody's good at it or not, or, whether they need to be disciplined in some way. It's more a place where people can learn for themselves. Oh my gosh, I didn't use as many words. I didn't have as much eye contact. I didn't even know I was doing that. And that way they can learn from their experiences in it. So I'm going to now turn it over to Dr. Eiler for a conclusion, and then we'll open it up to Q&A.
Great. So I'm going to sort of pick up where Dr. Beaton took off or left off in terms of talking about a few of the kind of exciting new things that we've been doing in the Institute and in my center. And specifically, one of the use cases that was mentioned by Dr. Bloss in the beginning was this idea of how can we measure moment to moment the expression of empathy and compassion in interactions to assist in this kind of formative feedback. So one way is through virtual reality and EEG, and another way may be through using AI to assist us. So going to go to the next slide. Um, so we have two projects right now that are going on. One is we are interested in understanding empathy and compassion of people who are leading peer support meetings. And so we have videos that we're trying to rate the empathy and compassion of the peer supporters. And then also a study where we're trying to rate empathy and compassion of medical students who are interacting with simulated patients and also have in a video setting. So we have videos of these things. So we have both audio and visual third-party ratings is what we're looking for. So as we were approaching wanting to understand and measure empathy and compassion in these two settings, we considered a couple of different things. So the first thing is, who are we trying to measure? We're trying to measure the leaders and the peers in these peer support meetings. And for the second case, we're trying to measure the empathy and compassion of the student so that eventually we can give them feedback. What do we have to work with? We have these third-party observer ratings is what we're trying to create, both sort of trained raters and untrained raters to these videos that we have. So we're looking at both verbal and nonverbal expressions of empathy. We're going to be trying to look at when were there opportunities for empathy and compassion, how was the affective and cognitive empathy expressed, and how was compassion expressed. Why do we want to do this? Well, we are interested in providing formative feedback, both to the leaders and the peers in these peer support settings. How could they improve the empathy and compassion of the peer support setting? And also to measure outcomes of any kind of training that we might do, and to provide, again, opportunities for formative feedback, particularly for our medical students as they're learning to be authentic in how they express empathy and compassion in these situations. When we thought about what measures are available, unfortunately, we couldn't find an existing measure that was ideal for our needs in either of these cases. Most of the measures that we have are not made to make these moment-to-moment ratings. They are usually sort of a one-time thing, or even when it's about like clinical interactions, it's usually after the fact, one summary rating of the whole interaction. So we needed to come up with something that was time varying on a very short time scale. But we also recognized that the time and the resources needed to have human raters do those kinds of ratings would be very high and maybe prohibitive for the types of ways that we would like to use these ratings. So that got us into the idea of, could we train a machine or an AI machine using machine learning to simulate the responses of the human raters so that we could have more efficient ratings. And also we could take advantage of the fact that with AI, you can usually interrogate which features were the ones that the machine was relying on to give the rating. And so it can help us actually maybe figure some things out that human raters may not actually have access to in terms of why they made the rating that they made. So we are in the process of developing and rating these things. We've developed some momentary ratings. The empathy and compassion ratings that we are doing in both of these studies include making ratings of both verbal and nonverbal behaviors, thinking about whether the people are displaying attention, reflection, validation, warmth, a lot of the things that you all were saying in the chat in the beginning. Assessing sort of how willing do they seem to be giving empathy and compassion, and also just making some notes qualitatively. What about the interaction made you give the rating that you did? And then there are some things that are study specific. So for study number one of the peer supporters, the situation is very structured. The format of the meetings is the same every single time. And so we have very obvious places where empathy and compassion could be shown, whereas in the video with the of the students interacting with the simulated patients is not as clear when there are opportunities for empathy. So we're doing a first step of going through and rating, this is where empathy and compassion could be shown, and marking those, and then we'll go back and do the ratings after that. So this is again highly complex for for the human raters, with the eventual idea being that we will kind of create this AI algorithm based on the human ratings, which will then allow us to understand better which empathy and compassion features actually predict the human ratings. Also, we can then bring it back to our peer supporters and to the medical students, and together with them, interpret the output from the AI, design how they would like to receive feedback, and then build a feedback application. Ultimately, for example, we might want to have a situation where a medical student could watch the video of them interacting with the simulated patient, the actor, and they could be given little pop-ups like, great job with your eye contact, or this would be a good opportunity for you to get on the same level as them, or we noticed that you reflected on their emotions. This is highly related to people's ratings of empathy and compassion. So kind of giving them these little pop-ups as they watch their video. So that's kind of the ultimate of where we would like to go with this project. So now that you've heard a little bit about what's out there in the field of measurement, as well as some of the new things that we're working on, I wanted to turn now to kind of what you can do right now to, if in the cases that you're bringing, the places where you want to measure empathy and compassion. So I would start first with thinking about, as Cassie mentioned, sort of who are you trying to measure? What's your population? What are you trying to measure? Which construct, whether it's compassion or empathy or empathic concern or relationship, sort of the recipients receiving compassion or challenges to compassion, really figure out what construct is important to you. Think about how you're going to use it in the future, sort of the why, and then also then figure out which instruments. Are there any existing instruments? And the website that will put, again, the website link into the chat so that you can, again, go and see if any of the measurements and the instruments that are out there already are ones that fulfill your who, what, and why. And also keeping in mind that if you're thinking of measuring change in any of these constructs, to look into whether people have used it before and how sensitive this measure is to change. Is it reliable enough that you'll be able to detect a change over and above just like normal variation in the construct? And then once you've decided on which measure you're going to use, when you actually use it, there's a few things that I think you should keep in mind that we have noticed in using measures that are off the shelf in the past. One is make sure that if there are any licensing requirements that you use, that you fulfill those licensing requirements, because you won't want to be surprised later on when you go to try to publish it and somebody says, can you show that you have a license, and you don't. Second, you want to be faithful to the administration requirements. So if there's a manual or instructions, you want to try to do that as closely as possible to how the original developers did it. Thirdly, you want to make sure that you administer it in a way that is, again, similar to the way that it was intended to be administered, or if there are options that you can use, like online versus in person, doing that. Scoring, again, making sure that you're scoring it according to the article or the manual. I have had a lot of students who've come back and said, whoops, I scored all of these, but I forgot that item number 7 was supposed to be reverse scored, meaning that you're supposed to, low answers were bad instead of good. So make sure you've got the scoring correct. And then, as was mentioned before, triangulate, maybe use different methods, particularly if you're developing your own bespoke instrument and then adding that to ones that are validated. It's good to have validated instruments as well as new ones in the mix. Okay, the next thing that you want to think about is, okay, now you've used your measure, how are you going to interpret it? So make sure that when you are reporting the results of your measure, that you actually report the reliability of the measure in your sample. So that would be like, a measure like Cohen's, like the alpha measure or others, but you want to do it within your sample so that you can see how reliable was it in your hands. Also get stakeholder input. As we mentioned before, it's really nice to look at the results with the people that are being affected by whatever you're going to be saying about it. Um, Also, again, if you're measuring change, you want to have hopefully had a comparison sample that didn't get your intervention, so that, or a control group, so that you can look to see whether the change in your intervention was greater than the control group. But if you don't have that, then if you have some examples from the literature of how much change is expected over a given period of time, you could compare that. We mentioned before cross-cultural considerations. You want to make sure that your instrument is being used in a similar cultural context to how it was developed. And if not, you're going to need to revalidate it in that context. And then finally, just again, as I think, again, Cassie was mentioning, I'll just echo that we want to think about this in a growth mindset as opposed to a deficit mindset. So when you're interpreting the results, instead of saying this group lacks empathy and compassion, you could say this group has room for improvement in empathy and compassion, and just always be thinking about how you could use your results for people to get better in these areas, as opposed to kind of pathologizing lack of empathy and compassion. Um, if nothing out there suits your needs, you are obviously welcome to develop new measures. As you see, we've been doing that in the Sanford Institute, starting with a model or theory of what you want to measure and exactly getting down to the exact construct, thinking about how change happens if you're measuring change and whether you think it's going to be linear, that is, people just get better and better and better on something, or is there a period of sort of stable stasis and then all of a sudden there's an aha moment where you get a jump, or maybe, which we've seen a lot with empathy and compassion, that you actually get worse before you get better because you have that self-awareness that you're not as great as you thought you was. And then as you learn more, you start to being able to increase and enhance your skills. Get multiple stakeholder input at all stages of developing a new measure. You want to validate and then cross-validate in other samples. You want to create a manual so that other people can use your measures, and you want to establish the norms for how often you think that things will change. And we would love, as an institute, to partner with you. If you're interested in developing new measures, please get in touch with us and we can think about how we could help you to get to where you want. So that's all that I have, and we wanted to move now into the Q&A. So you can either put your questions in the chat, or you can unmute, raise your hand, and we'll call on you.
Thanks, Lisa. I've just been tracking a couple comments in the chat so I can kick us off. But yes, please do put your questions in there. There's one question from David Wing. Is Sanford wanting to build new measures or more interested in finding the quote unquote best measure of those that are already out there? I have some thoughts on that, but I'll put it over to Lisa and Cassie.
Sure. I would say yes, we want to build new measures. And as Cassie mentioned before, it's really hard to say, like, what's the best measure. All measures have problems depending on what you're trying to apply them for. I don't know if you want to say more about that, Cassie.
Oh, I replied in the chat and just said, all the vast majority of existing measures are self-report and, as we mentioned, face valid and highly correlated with social desirability. But I do think optimizing the ones that exist or building new ones that address the weaknesses of the existing ones, and maybe ones that incorporate new technologies, which I know you are so good at, David. So let's do it. That'd be really fun.
Thanks. Greg?
Yeah, thanks for this presentation. It was really interesting. Um, One thing that I've been grappling with a little bit lately and that came up in the discussion is this sort of differentiation between felt empathy and expressed empathy. And it seems to me like it can go wrong on either levels, and they go together, but they can be pulled apart a little bit as well. So I could think of an example where a clinician is really feeling empathy in the right way, or feeling a lot of empathy for their patient, but it's not expressed in a way that the patient picks up. But I could also see it um, where they're expressing it a lot and the patient feels cared for, but they're becoming burnt out because they're doing it in a way that's not like sustainable, perhaps. So I'm just wondering how you folks kind of grapple with these two different levels. And do you see them as sort of like this different sides of the same coin, or do you see them as different trainable skills? Or what do you think about that?
Cassie.
Sure, I can start. And this is where Cinnamon's description of the differences between empathy and compassion can really come in. That empathy, when we talk about compassion fatigue, it probably would be better called empathy fatigue because the feeling of empathy can be quite distressing, especially if the people that you're interacting with on a daily basis or frequently are highly distressed. And if you're helpless in a way to help them with the kinds of distress they're feeling. And so when you feel that distress, the action you take can unintentionally be something that is designed to reduce your own distress as opposed, or even try to reduce the patient's distress when they're like justifiably distressed. So it doesn't feel right to the patient. Whereas some definitions of compassion are that you have a deep concern and you feel moved by the plight of the patient, but you're not feeling their distress. You're feeling activated to see if there's anything you could do. And if nothing else, to say, you know what, I don't know the answer to what's going on with you, but I am here with you. I'm going to work beside you, and we're going to try to figure this out together. And that can be a kind of stance that is not depleting of energy, and it feels authentic and genuine and humble to the patient.
Yeah, and I'd like to say that we need more measures of that, what I like to call exquisite empathy, which is the ability to recognize the suffering of others and move very quickly into a compassionate stance instead of wallowing in the empathic distress. So that transition from empathy to compassion is something that hasn't been measured a lot. And I think is something that another reason why it's important to have these kind of momentary measures of empathy and compassion because you want to catch that moment where people are moving or not moving because I think that's the key to understanding the potential negative consequences of empathy without compassion.
Thanks. Edwin?
Yeah, thanks. Sorry, I have a little bit of a cold, so I sound a little bit hoarse. Yeah, I'm the director of the Empathy Center. So our organization has been, working for years, offering empathy out in the public. We've been mediating conflicts, left-right conflicts using empathy and empathic mediation. And our goal is to make mutual empathy a core cultural value. But the one thing problem that I'm having is that this I totally disagree with this affective cognitive empathy model that's been sort of created in academia. The definition that we're using is kind of starting with Carl Rogers, from the 50s and 60s and how he used empathy. And he never differentiated an affective cognitive split when he was doing active listening, with his clients, and we do that in small groups. You can't really pull that apart. You're listening to someone for their full whole self of who they are. And what you were saying, Cassandra, that if you're empathically listening, like he listened to like psychopaths, I mean, just really difficult people, and he didn't go into empathic distress because he was grounded in his empathic presence. So, how do we solve this problem? Because I'm finding it a real problem in terms of our work. This whole affective cognitive model, which I think is totally inaccurate and actually is a hindrance to an empathy movement. So, just wondering what you think
Yeah.
about that.
Well, I can start and then pitch it over to others. I mean, I think the short answer is I don't know the answer to your question. But certainly, I'm familiar with the work of Carl Rogers and kind of giving unconditional positive regard, a really important influence on the field. Um, but I think what you're bringing up, and this was also, I think, raised in the last question from Greg, which is the issue of how we define the constructs, right, of empathy and compassion. And I mean, I think construct definition is such a critical issue for all latent constructs, sort of things we want to measure, but we can't really see, right? And so, and I think, empathy, as you're raising compassion, other latent constructs, there's differing views on sort of what are the domains of those constructs, what they're kind of comprised of. And it has a really critical like role to play in measures, right? How we develop those measures. So I don't know the answer to your question, but I think that one thing we've been talking a lot about in our institute is just the importance of construct definition in terms of how we go forward to kind of validate existing measures, but also develop new measures that are reliable and valid. But I turn it over to Lisa and Cassie for other thoughts.
I would just say that also these distinctions are only valuable to the extent that they move the field forward. And so it sounds like that in your work, that distinction is not valuable, if maybe even be harmful if people misinterpret what you mean by affective and cognitive, or if they use that distinction to change the way that they listen to people and the way that they do things. I think for people who are looking at the neurobiology of empathy and compassion, that's where I think some of that distinction has come from, and perhaps it is useful at looking at that level of analysis. But I don't think we want to reify anything that we've done in terms of constructs or definitions as meaning that that's valid in every context or for every application.
Yeah, and I would just say that all science and scholarship is better practiced with humility. And so when we put a name on something, it already divides it from the lived experience. And then when we tear it into component parts, it takes it even further from lived experience. But science is one way to know truth. And as we deconstruct things into their different parts and look at them and try to reassemble them, often it does have a very positive impact out in the world. And sometimes it's becomes so abstract to be not useful in certain situations. So I'd like to sometimes say, when we try to examine a butterfly too closely, we have to pin it to a card, and in doing so, we kill the butterfly. So we don't want to do that. But we are kind of obsessed with doing science and trying to look at things in their component pieces and trying to stay humble as we do that.
Well, I'd
And
love to have a discussion sometime about definitions. I did put another model in there, so just at this point, glad to
thank you.
discuss it. Thank you. Thank you.
Thank you.
And I wanted to respond to Lindsay, who says in the chat that ask what we think about using some of these AI measures of videos of compassion and audio recordings of compassion to give feedback during rounds. I think that would be an awesome, or sort of after rounds. I think that would be an awesome way to not only work with people who are in training, but also with people who are currently clinicians, to give them feedback when they have a little bit more time to think about sort of, okay, how could that have gone better? What are some of the tips and tricks that we might get out of that? Absolutely.
Yeah, and really important to normalize challenges to compassion. I remember when hospitals moved from trying to find the one who's to blame for a surgical incident to rewarding the person who said, I messed up and I left a sponge in or something. Like, it's actually good for people to be able to say, I completely lost my compassion with that patient, and try to figure out what happened to me. Was it something in my, am I burned out? Was it something that happened that triggered me? So to think about assessment of compassion and empathy not as a values game, but as a growth game.
Thanks, Cassie.
Yeah, I agree
Other
with that. I also think that one thing that we have been thinking about is also what level do we measure empathy and compassion? And so we've been talking a lot about measuring it on the interpersonal or personal level and among individuals. And there's a lot to be developed still in terms of measures of institutional or organizational compassion and empathy, and what that would actually look like, and again how you would measure it. Those things are much more nascent and very important. I think also getting back, Greg, to your point of to some extent somebody could have the desire to be compassionate, but the system doesn't give them the time, opportunity, resources to meet that desire, and that also can be a source of burnout. So needing to make sure that we have ways of measuring these at a systemic level so that we can do both sort of a bottom up and a top down approach to making healthcare more empathic. Bharati?
Thank you so much for this wonderful talk on empathy and compassion. I am a therapist with over 30 plus years in the field, have worked with Kaiser for many, many years, and I am now retired and have my private practice, and I'm a brain spotting consultant and a trainer for India. So I have a lot of questions. Uh, Especially, I like the part I've been doing a lot of readings on neurobiology of empathy and compassion, Tanya Singer's work and Olga Klemecki's, and I attended your talk at Balboa Park as well. My question is, I do work with doctors from Kaiser who are so hard pressed for time, and like someone here mentioned, felt empathy versus expressed empathy, right? They feel it, but they don't have the time to express because once they go on that channel, it can open up more and more stories from the client or the patient. Um, does your work with the Institute primarily work with doctors? Do you work with therapists? That's one question.
Yeah, so sorry, before I answer the question, I just wanted to say that we really value folks' feedback. And so in addition to acknowledging all the people that helped with putting this together in the study scoping review, we want to put this QR code up there for folks so that they can give us some feedback about this and so that we can improve it for future offerings. So please do that while I'm answering this question. We're very interested in other types of healthcare providers, including therapists, nurses, advanced practice providers, and we've started to include those in some of the work that we support. And I think, one thing that we have noticed is that that these skills could be applicable to anyone and everyone. There are some professions where I think there's more training, like in these types of skills than there are in the typical medical school curriculum. So that's kind of why we're starting with medical school students, and people who haven't had as much training, whereas with the therapist, there's more training in sort of how to interact directly with patients emotionally and how to hold negative emotions. So we start with the medical students.
And the other thing I would just add to that,
Chaplains, yes. Sorry. Also just echoing what Susan said. Absolutely, chaplains.
the other thing I would just add to that as well, on the training side, we actually have a number of clinical psychology doctoral students who contribute to the work of our centers and the work of our institute. They are key contributors, and so we're sort of growing a workforce through our clinical psychology doctoral students as well. So thank you for the question. So we are at time, so we should close out our webinar. I just want to give thanks to everybody who helped make this webinar happen today, especially Kim Center, who was tireless in keeping us organized and on track. And I just want to close also by thanking all of you for attending today, for your thoughtful questions, and we hope you'll keep in touch with us and help us kind of move this work forward in general.
We have a save the date. Kim, if you want to move to the last slide, we will be having an in-person forum at Scripps Seaside Forum here in La Jolla, February 10th through 12th in 2027, where we would love to have you come and join us in person to hear all of the latest and to hear from you what everybody else is doing in these spaces of empathy and compassion, particularly in healthcare.
Thank you, everybody. Have a great day.